topic at hand, and that is that many of these patients, after neurological impact, injury, or the diagnosis of a neurodegenerative disease, suffer with post-trauma vision syndrome. The topic is quite hefty. There's a lot of information in the slides, and as time permits or don't permit, I will be covering a lot of the detail, but rest assured, if I start skipping over some of the detail, the slides will be shared with everybody, and if you want to go through that and, ascertain yourself as to the smaller details that we might have missed, please do so. And if you need to get further information, you are more than welcome to email me or just phone me. So let's get rolling after all the formalities is done. So let's think about patients that we see. I'm going to consider a case of Mr. 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 MR is a 60-year-old male. He's an IT developer, and he presented with the following. He reported that he had a cerebellar infarction about 2 years ago. He had left vestibular involvement. He suffers from chronic disease, included diabetes and hypertension. His complaint was that his vision is not right. He can see, but he feels strange. He had a previous eye test which confirmed 20/20 in both eyes, and he had a pair of multifocals made. Eye health was normal, but his balance is affected, and he was really embarrassed because he said that if he tries to walk, he looks drunk and he needs a rollator or an assistant to help him. He complained about poor concentration, slow work pace, his memory was affected, and he had excessive fatigue. The next case we'll consider is of a younger bloke, Master CS. He presented with concussion. He was a feisty guy, 16-year-old, as they come, rugby player. He reported the first concussion in March 2019. As we know, 50% of concussion patients and sports people get another injury in the same year. So he had a second one in September 2019, and then a third one, which was 2 weeks prior to presenting for the eye examination. His health was great, but he had a little problem because he needed crutches to walk. When asked about why he's wearing crutches, why he's using crutches to walk, he says, "Oh, I'm falling backward and I've already broken 2 of my parents' coffee tables in the house." Asking about his balance, he said, "It's hectic. I can't walk and I can't stand unassisted. I can't see to read, can't do schoolwork," with a little grin on his face. He seemed not too concerned about that one. He said that his headaches is intense. He was confused and he had severe photophobia. And again, he had an eye test after his second concussion, and it was reported that he has 20/20 vision. He was obviously very uncomfortable and in a bad way in terms of his functionality, and it was interesting to manage him as a case. So if we look at the post-trauma vision syndrome, I would like us to review a little bit on the background of vision. And a definition that I really enjoyed is a definition penned by Dr. William Padula. He's an optometrist in the US, and he's a founding father of the Neuro-Optometry Rehabilitation Association. And he states that vision is a dynamic, interactive process of motor and sensory function. It's mediated by the eyes for the purpose of simultaneous organization of posture, movement, spatial orientation, and the manipulation of the environment, and to its highest degree, for manipulation of perception and thought. So gone is the Google definition which says vision is sight, and sight and eyes work like a camera, and that's about it. So we know from our background that it's much more complex, and that we often overlook that exact complexity when we concentrate on our pathology, CPD, on macular degeneration, glaucoma, corneas, contact lenses, and the like. So let's see. The patients we see who had a neuro compromise of whatever kind usually poses us with a challenge. We know that there are over 1 million nerve fibers that exit the eye. These fibers is more than 70% of all sensory fibers in the body. And because we have such a vast extent of fibers entering the brain from the eyes, we also know that 70% of the information that we receive from the environment comes through the eyes. We have a challenge in the sense that the higher visual organization and the cognitive processing and visual imagery relationships associated with the visual organization is poorly understood even to this day, despite all the technology we have to research this. We have a limited awareness of how systems of movement and posture relate to visual processing. So, our thing today is how vision influences the motor and other systems, and to understand that when patients come to us with vague symptoms that's covert and that's not clearly defined when they come sit in our chairs, how can we start to probe it and what we can do to make it better? So if we look at the senses, we look at the professions managing issues and difficulties in the functionality of those senses, we find that we end up with professions that sits in silos. Optometry and ophthalmology, supposed to be very closely interrelated and joined and partnered, but we know that even today we do find difficulty to bridge the gap into the co-management with our specialist colleagues and them co-managing with us. We also know that if we see a patient who has some kind of a audiology difficulty, we don't know much about that and how that influenced the patient in his visual perception and how the visual perception influences the auditive functionality. So likewise, we have the same difficulty with the interface between all of these professions: neurology, occupational therapy, physiotherapy, neuropsychology, speech and language pathology, and therefore the colleagues who deal with kids with learning difficulty understands this very issue, is that it's so difficult to take a complex difficulty or disruption and try and solve it just from one profession as an individual perspective. So if we look at neurosensory integration, if we look at the individual organs, it's really difficult to understand what the influence of the disruption, any of it, is, especially if we view it or have an approach that they function as isolated systems. It's an ineffective approach to understanding the integrated higher order sensory motor function. We know that the brain processing and decision-making is not based on a stimulus-response model. We know that we organize responses prior to receiving a stimulus on the basis of a response-stimulus-response modality. But do we really think about the role of vision in this interface and organization of the response-stimulus-response? Or do we get caught up in our making sure that the patient has a good refraction, good VA, and healthy eyes? So when we look at the neurosensory integration, it's all about vision and its influence on attention, anticipation, and action. So when we then look at the visual system is divided into two primary systems, being the focal and the ambient system, and these two systems are in constant flux and balance. The focal system is the central system. We'll go into the detail just now, but the focal system tells us what it is that we engage with, whether it's detail, whether it's an event, whether it's objects. And the ambient vision gives us the reference as to where is this what that we experience or see. Where am I in relation to that detail or object that I interface with? The systems simultaneously process different types of visual information. We know that the focal is more centrally located. The ambient brings information more from the periphery. They enforce one another, but neither of them can work in isolation. So there always needs to be a little bit of each of them engaged. And there's always one that's slightly more dominant. So if we go into the detail, Libowitz, Post, and Trevarthen started this theory in the 1960s. They had very, very high resistance because at the time we didn't have the technology to prove that everything they postulated is true, untrue, and therefore, as it is in science, if you can't prove it, it doesn't exist and it's not true. But over the years, their theory has been proven. So if we look at the two systems, we have the ambient system, and this is the important one, although only 18% of the fibers is dedicated to the ambient system, because the ambient system is our proactive system. And that is the system that feeds information forward to the brain. So once the information is fed forward, we can latch onto the information with our focal process. We can react to it or with it, and we can have a certain feedback from it. So if we just concentrate on the ambient vision for a start, we look at it and it is dorsally represented in the brain. Dorsally because it goes to the parietal lobe. We know that in the parietal lobe we have the motor and sensory motor processing taking place, and therefore the ambient vision is critical for our balance, posture, and sensory motor function. It tells us all about movement and spatial localization, and it gives us the basis for our figure-ground segregation. In other words, whenever we have any detail, what is the relevance? What is the spatial relevance of the detail that we engage with? It's also the critical part of the system that's engaged in the fight or flight response. We know that when somebody has trauma of any kind, they either have a response where they go into fight, or they flee, they run away, or they disengage with whatever they are faced with. If we then look at ambient, we also realize that it's a subconscious system. So we don't even think about it. We don't even think of engaging it. And already it is giving us critical information for our survival and our smooth functionality in terms of the integration of our various systems. Then, if we look over to the right-hand side, we have the focal system, and that's ventrally represented in the temporal lobes, where we concentrate on detail and interfacing with figures and letters and language and everything that needs higher order processing. It's slower because it doesn't have a shortcut bypassing, first going to the occipital lobe. It's conscious. So we have to think when we engage the focal vision. It's all to do with object identification, as I said. It's guiding our fine motor coordination for reaching and grasping. And it serves secondary to the spatial pathway. So if the focal system doesn't have the ambient or the peripheral reference, we are lost in space. We can have as much detail as we want, but we don't know how to use that detail in achieving our higher cortical processing. So, spatial visual process is the feed-forward phenomena. Visual information is relayed from the midbrain directly to the occipital cortex. It takes a shortcut. It pre-programs information for vision to the higher cortical areas, and it evaluates the information in vision, and it gives it a spatial relevance, so that when we focalize on the detail, we know where we are and what we want to do with it. In the developmental process, spatial vision allows the development of our awareness of midline, position, and orientation concepts. So this forms the basis of balance, movement, and coordination. Quite important to remember when we deal with a brain-injured patient. So, as we said, spatial and focal visual processes needs to be closely integrated, and they need to easily swing back and forth between one another, handing over the baton to one another, depending on any given circumstance in which we need to function. Neuro disease or traumatic brain injury disrupts this integration. And it's very, very important, because if we only concentrate on the 2020, we forget about the fact that we need this critical integration and that we need the spatial relevance for that patient to use that 2020 quality they've got. So if we have an imbalance or disruption, the information that's eventually received in the occipital cortex is without spatial pre-programming and relevance. When a patient sits in a situation like this, we refer to the condition as focal binding. And if you want to imagine yourself looking at any environment, and you think about figure ground, when you look at something, you focus in on the detail, and the background sinks away into a blur or less relevance. When you are in focal binding, that segregation between foreground and background, figure and ground, falls away. And it seems that everything you see is just highly pixelated chaos, because there's not relevance and you can't segregate that relevance from one another. Think about the patients with the neuro injury, and when you see them, when you talk to them, and when you consult them, keep in mind that if they can't tell you exactly what's going on or what is bothering them, start wondering whether they're not in focal binding. So, as we said, all the systems interface with one another. All these sensory fibers that enters the brain from the eyes, and the bimodal visual system shares and matches information with 30 to 40 brain processing areas. They share about the 30. They're still busy to prove that it's actually 40. So there's lots of research being done, and the functional MRI and all the various weird and wonderful scans that's available today is just amazing if one starts to pursue how they research it and how they prove all of these theories. So these information centers shares and match information with the sensory systems like the vestibular system and the kinesthetic process. All of these systems provide information for balance, posture, and movement. So, with the neurological events, trauma and disease, it disrupts the bimodal visual system and its interface with the sensory motor systems. Posture is managed subconsciously. So, if we start giving attention to posture, we can't attend to other informational action. We are so preoccupied with thinking about staying upright against gravity that we basically can't do anything else. So vision provides organizational set to the sensory motor system. And when there's a mismatch, the sensory motor system affects the visual processing. And likewise, the disrupted visual processing affects the sensory motor function. And so we carry on in this big downward spiral. When we look at postural equilibrium, we know that it receives input from the visual, vestibular, and proprioceptive triad. And all these systems provide the information for balance, posture, and movement. So whenever one of these systems are compromised, two of those can take hands and they can still save the day. But when we have compromise to two of these systems, whether it's only slight, we find that we are very soon in very serious trouble. And our patients have big difficulty in functioning from that perspective. Now we need to go into some anatomy, just as a reminder, and we start to use the words that we long forgotten. So if we look at the superior colliculus, it's our midbrain hub And we can refer to it as a change station because it receives visual spatial orientation information, eye movement control, and information on the spatial relations. And it matches that with the information from the vestibular, tactile, and auditory systems. And together, all of them are going to have a nice party around the braai fire. So, from there, the next critical area to consider is the posterior parietal cortex. And as you can see on the diagram on the screen, that area in the brain hosts a variety of visual processing centers. We won't be going into detail about that, so you don't have to be too concerned. This is a convergence hub for visual proprioceptive and vestibular information. It gives us the awareness of movement and direction of movement of objects. It helps us to localize objects in space relative to ourselves. It gives us an awareness of the position of objects relative to one another. So it's organizing and preparing our bodies for action. Now, we have the big guns together. We have the midbrain, superior colliculus, and cerebellum. And again, thinking about the braai fire and the party. The rostral, midbrain, and superior colliculus matches the visual information with the sensory motor fibers from the kinesthetic, proprioceptive, vestibular, and tactile systems. And there the guys are standing around and they are chatting to one another. Down comes the wife, and she's the party regulator. She comes and she monitors that nobody is having more fun than they should be having. And she also sees whether she shouldn't fire up the party a little bit. So the cerebellum monitors minify or amplify the input and format the information for feed forward. The higher organizational cortical centers come and stabilize and anticipate the information for action. It is then fed forward to the occipital cortex, and the occipital cortex stabilizes the peripheral retinal images, controls spatial environment, and the binocular fusion. And so, everything and everybody working together give us a nice, meaningful party of good spatial relations. Social relations, something that we forgot at this stage. Ambient vision is matched with balance and sensory symmetry and used for spatial orientation. And this is very important. We have to remember that the ambient visual system is what helped us in our developmental phase to establish our balance and our coordination in movement. And that developed in a symmetrical fashion and everything calibrated with one another. So if we are now going to have a disruption, a sudden change in the patient's physique, like when the patient have a hemiplegia or paresis, we get a certain level of asymmetry. And we have a disrupted spatial calibration between the various senses. So what's vision going to do? Vision needs to be the Superman. Vision needs to try and stabilize this whole chaotic situation. And we know that the visual system is the dominant sense in the triad of vision, vestibular, and proprioception. So the ambient visual system is the master regulator for symmetry, and what it's going to do is when the body is suddenly changed into being hemiplegic, the foundation of our motor system sinks away on one side, like a foundation of a house that crumbles and sinks. And what happens? This whole relationship of perfect balance and calibration now stands on a very uncertain foundation. And now we have a difficulty with interfacing with our environment. So here comes the ambient system. It expands or contracts our inner spatial awareness to manage this balance dysfunction. And this now is transferred to our posture, the posture of the patient. The ambient process uses feed-forward mechanism of the occipital cortex, and it projects an expansion and contraction now into the external space. So first of all, it realizes internally that something is wrong, it activates, and now it projects it into the outer space. And now we find that the patient experiences a distortion of their higher order spatial environment. So what happens then? When you have an external visual space disruption, the patient with a sudden asymmetry in body posture experiences a visual impression of a distorted, either expanded or contracted relationship of space. So what happens? The whole environment starts to look weird. It looks sloped or slanted. If you look at the floor, it seems sloped downwards or sideways to the right or left, or even upwards. Walls are bending. Some of the walls are bending and some of the walls are expanding. And instead of seeing a rectangular frame of reference in a room, if you look at the opposite wall, it looks like a trapezium. The big thing is the patient is unaware of the inaccuracy as there is no external references to normality or space. They don't have any reference because what they see is what it with neuromotor characteristics like hemiplegia, hemiparesis, flexion of the body either bent forward, extension of the body, hanging back, veering backwards, or any side neglect, whether it's the right or the left side neglect. The parietal lobe is the most prominent area of injury for patients to experience visual neglect. And we know that with brain injury, there are very often visual field disruptions. And it's not to say that a patient who neglects the one side do have a visual field loss. And that is something that's very, very important to distinguish when we see these patients. Do they actually have a field loss? It seems as if they have a field loss when we look at them clinically. But we have to make sure that when they neglect that side, is it because they don't see it or is it because they don't know it's not there? So the associated symptoms, as I said, the floor may look tilted, also floors are shifted or it's moving, and the person will lean or increase weight bearing to the unaffected side. So they compensate in their motor system. And then the visual system responds, and the vestibular system decides that it won't be left out of the party, and the vestibular system activates. And so everything now is in high alert, but they find a difficulty to function in cohesion. So, post-trauma vision syndrome is what happens when we have a breakdown in the organization of the central nervous system and automated responses. There's a broken link between the automated and pre-conscious nature of the visual system. Remember, the visual system feeds 70% of the information. So if the visual system is disrupted and the focal and ambient system is not finding one another as they used to in the past, then there's a big maladaptation and we see a lot of non-functional responses in the patient's behavior and experiences. So, causes of post-trauma vision syndrome is typically conditions that causes Neuro Compromise, cerebrovascular incidents, whether the patient had a clot or a hemorrhage, trauma, whether it's an open or closed wound, tumors, neurodegenerative disease, Parkinson's, multiple sclerosis, and Alzheimer's are amongst these. Many people with Parkinson's, have a very stooped forward posture, and they tend to lean to one side. And when we assess these patients for visual midline shift and we correct it, they typically end up asking, how did we get it right to change the angle of the floor? Because it's been skewed for the last few years. It can be caused by infections such as meningitis, Lyme disease, and malaria. Lyme disease is getting a lot of attention in the Northern Hemisphere at the moment. Here in South Africa, we believe that we have a similar situation of neurological involvement when patients are bitten by ticks and get tick bite fever, insect bites, and then obviously concussion. Concussion is a topic that we can really spend some time on because that is a vastly neglected field where optometry can make a big difference for the patients. And then when a patient had surgery and the brain has been opened up, nothing is ever the same again. So let's look at spatial vision. So if we think about the spatial vision, we don't have it. It will be very difficult to interpret the image on the screen. Spatial vision releases focalization for movement. So if you concentrate in your focalized system and everything on this image becomes pixelated, you will not know where you are if it's not for the spatial vision. Spatial vision creates the relationship for verticality. In other words, it tells us what's the top and what's the bottom, what's the front and the back, and the right and the left. It frees up higher level processes for postural organization and control. It suppresses the background information to allow attention, and it's a major contribution to overall cognitive performance. So think for yourself, if you look at this picture, if you look at the environment, and everything becomes pixelated, what happens to cognition and what happens to your normal functionality? So when the spatial visual system falls away, we end up in focal binding and an inability to release detail. We are completely overstimulated by our environment and we can't function in busy, crowded places because of our sense of visual chaos. Everything is pixelated and detailed and overwhelming. So patients complain about movement of print or the ground swaying when they walk, when they are in focal binding. So in an acquired brain injury, we have functional change, short circuit to the brain's organization, stationary objects seem to move, words and print run together, walking, we feel like we're walking on a tiled floor, get irritable due to noise and crowds. And it's interesting if you look at the noise, irritation, and the hypersensitivity to sound. When your visual system is not working, the brain tries its best to get the information from another sense. And when it switches on the audition and the auditory system, everything becomes chaos and overwhelming. So these patients suffer with high anxiety. And because they find it difficult to find the source of their disruption and their disease and their complete desperation of getting themselves back to normal, they are very anxious and they end up being treated for depression and all the psychiatric kind of conditions. And we forget that the fact that they see 20/20 and the eyes are healthy and there's no problem there is not to say that vision is actually intact and functional. They feel shaken and stirred, as I said. They complain about COVID symptoms. They very seldom come and tell you that I see double, or I see that the floor is sloped down, or I feel overwhelmed in my hearing because I can't see properly. They will tell us that they have attention problems, concentration problems, difficulty with cognition and memory. Many of these patients stutter all of a sudden, not because the speech area in the brain was affected, but because of the disruption of the focal and the ambient visual system. They don't have a sense for time and space and rhythm. And therefore, they find difficulty to organize their speech. And obviously, they suffer in their motor performance. So, post-trauma vision symptoms, what will the patient say? They complain about blurred vision, unstable vision. They will tell you that they close one eye. And that's something that we often hear and we know immediately, okay, that's the binocular system. But many of them come in and they can't keep their eyes open when you consult them because the vision is so overwhelming, they just want to close it, get rid of it, and just calm down. Objects appear to move, they have poor concentration and attention, they end up in a staring kind of behavior pattern. Because when they look straight ahead and they switch off the vision in the brain, they can escape their discomfort. These patients, guess what? They are great patients for the dry eye experts around here because they all suffer from dry eye and irritation. Poor memory, can't remember names, places and faces, noise sensitivity. They have high visual fatigue. Headaches are at the order of the day. They're losing balance and they veer. So they literally seem like a car with lost wheel alignment. The coordination is off. Posture and spasms are plaguing them, and many of them end up for physiotherapeutic management when it's actually the visual system that induces this strange postural adjustments and adaptations. They're irritable and disorientated in noisy, crowded environments. They hate it when their family or wife or husband takes them for outings as a treat to the shopping centers because they're so overwhelmed visually. Very light and glare sensitive. So what do we see? If we examine these patients, we typically see in many cases a large exophoria or exotropia, accommodative inflexibility, ocular inaccuracies with fixation, pursuits and saccades, nystagmus. We see convergence insufficiency, low vergence reserves, because when they are constantly fighting to keep the two eyes together and we start measuring vergence reserves and we break their fusion, they find it very difficult, and we will very, very often see that when you do your vergence reserves, they will have a negative recovery point because they need all the help they can get. Make sure that we check for visual field loss. These patients have decreased contrast sensitivity because of the effect on the axons, because of the bruising and the injury. They have slow dark adaptation. The whole metabolic process is slowed because of the brain injury. They have poor spatial judgment and depth perception, and we need to look out for possible visual midline shift. So when we assess them, we do our general examination, comprehensive history as always, everything is there. We're very au fait with this part. We do a functional assessment, look at fixation stability. It's very important with these patients to check their dynamic visual acuity. Ask them to look at the chart binocularly, see what they can see. If they have a 20/20 vision and you start asking them to oscillate their heads from right to left, shaking as if you tell a kid, no, don't do that, and they start shaking their head and the binocular visual acuity drops, you have to see the red lights in the visual functionality. We check the saccades. King-Devick is a wonderful test to do if you don't have videography, oculomotor videography. There's a wonderful instrument. They call it the right eye. If you don't know about it, go Google it. Check the pursuits, fixation, disparity, and diplopia, because you need to know if you're going to sort these guys out with prisms, how much should you give? Dynamic acuity, as I said, convergence, vergence reserves, accommodative flexibility, and balance. And so for us as optometrists, balance is not something that we typically assess. And it is very, very important that we learn how to assess the patient's balance if they have neuro compromise. So, remember again, visual field defect, visual perceptual defect. Think about the neglect. Think about the fact that if I don't know that I don't register one half of my world, I will tend to veer into what is remaining of my world, my spatial world. So I will be off-center in my midline alignment, and I will aim for the midline of whatever part of the visual space I'm aware of. And whether you have neglect or don't have neglect, whether you have a visual field loss or not, the patients tend to respond in the same way. They veer when they walk. They tend to drift either to the right or the left. Think about the visual midline shift and identify that. And remember, patients with brain injury very often have horror fusionalis, where they have diplopia, and we put the lenses, we put the prisms on, and we don't get them to fuse. You can do whatever you want, you don't get them to fuse. So the functional model is to concentrate on the fixations pursued saccades. Think about the vestibular ocular reflex and the involvement of the vestibular system. Remember that the vestibular system triggers eye movements. If my head moves and my eyes fixate on an object, my eyes move in opposite direction. So if I have binocular instability, or if I have a eye muscle or a cranial nerve that's compromised and I start moving my head about, I'm exacerbating my difficulty with my binocular alignment. And sometimes I'll be single and sometimes I'll be double. And when I'm double, the brain doesn't want to rely on the visual system and it shuts it down. And when it shuts down the visual system, I am lost. I'm lost cognitively, I'm lost in my balance, I'm lost in my world. Convergence. Think about the guys who see 20/20 and they tell you that they can't study and they can't read. Think about the fusion, the perception, the motor skills, and the reaction time. Many of these patients, especially the elderly patients with Neuro Compromise, have 20/20 vision. They have a full visual field, but they have exceptionally slow reaction time. Think about how you're going to counsel them and consult them when they want to go back to driving. The behavioral model is the functional approach plus the prescription of lenses to affect function. That's where we use lenses in a therapeutic way. We use binasal occlusion to stabilize the spatial relations. And binasal occlusion is a wonderful, wonderful, wonderful treatment if you have a patient with horror fusionalis or a patient who have a non-concomitant deviation in the oculomotor balance. Jongh prisms is the one tool that we use a lot to help the patients re-establish their vision and their visual space. Balance board and walking rails to improve balance and movement, and the observation of changes related to attention, concentration, and memory. Look at the other things. Forget about just looking at the eyes. So when we look at the neurovision postural model, we as optometrists can't do this alone. It doesn't help us asking the help of the ophthalmologists, because the ophthalmologists look at us. They look at us to manage the patient's functional vision. So we need an analysis of the base of support and the biomechanical alignment. How does the patient manage their posture? We cannot do that. We need the physios to help us with this. Assessment of the level of visual skill relative to the postural organization. The physios need us, because if we can manipulate the patient with Jongh prisms, in many cases we help them re-establish their physical difficulty. We need a movement assessment of flexion and extension. The physio will look at that, and you will add the Jongh prism, and together as you work with it, within a question of 5 to 10 minutes, you can sort out the patient's difficulty that he's been having for 2 years already, 3 years already. I had a patient for 6 years, she couldn't stand up from a chair. So look at the head and neck alignment, look at trunk rotation, think about the release of focalization to establish change. Try and work towards releasing the patient from their postural binding. Now, the thing is, if you're visually bound, if you have focal binding, it causes you to have very ataxic staccato type of movements, like a little robot. Think about the bimodal concept of visual processing and rehabilitation and the pre-conscious versus conscious processing. That's all the facets that we work with when we help these patients recover. So let's quickly go back to the first case. If we think about stroke, we think about the first patient, 60-year-old male with his cerebellar infarction. He couldn't walk, he couldn't stand up from a chair, and what we did is we evaluated him. We know that he has a left cerebellar stroke. On his scans, we could clearly see, and it was actually shocking to see how well this patient adapted when we looked at the large area of atrophy in his cerebellum. He had a left cranial nerve 6 paresis, so the lateral rectus, and when we have a lateral rectus paresis, we know that the eye will be turning in an iso posture. So cover test confirmed that. decompensating esophoria, but it was non-comitant. It had a larger deviation to the left field because we know that the lateral rectus of the left eye pulls the eye to the left. And when that muscle or that nerve is compromised, we tend to go into a diplopia or a larger deviation into that side of our functionality. The distance, we also had an esophoria, was also non-comitant to the left field. Motilities was feel full to the right, limited abduction to the left of the left eye. Saccades induced dizziness and nausea. Remember, many of us forget to do saccades, and saccades is a dead giveaway of a patient to have neurotrauma and a destabilized visual system. This patient had low astigmatic presbyopia, so the multifocal lenses helped for one of the things that he had difficulty with. Now, if a patient is decompensated in focal and ambient vision, they find it very difficult to work with the input from multifocal lens. As we know, and I'm sure that Julina has given many talks on this before, is that the multifocal lens have a huge influence in patients who have a tight visual system. So we gave him single vision distance RX and near RX. We used near compensating basal prism, plus we used yoke prism with the base to the left. So we actually moved the visual space. We balanced we gave distance compensation with basal prism, and we gave neurovisual postural therapy. And the neurovision postural therapy is to re-establish the ambient focal and reintegrate the vision vestibular proprioception. Guys do the same. We sit with a concussion. We sit with this little bloke who's leaning forward on his crutches. When he stands unaided with the crutches, he literally falls over backward, and his dad has to catch him if I ask him to close his eyes. So, his refraction was plano, his near point of convergence was 38, so we know that there's already a reason why he finds it difficult to see close-up. He had a superior oblique paresis with a small little vertical. Saccades was inaccurate. The suits was full and tight with a midline jump. He had convergence insufficiency, accommodation insufficiency. His visual spatial relations was posteriorly displaced, where we checked his visual spatial awareness and accuracy, and he had a posterior weight shift. For this patient, we pushed plus, we gave him a plus 050 because we expanded his visual space into the peripheral area. We sensitized the spatial vision by giving him the plus. We gave him binasal occlusion to help him with the organization of space, and we gave him yoke prism base up. And that helped him lean forward a bit and re-established his balance. So these patients, unfortunately, don't do well just with a frame and a set of lenses. We need to do the neurovisual postural therapy. Usually we need about a minimum of 12 sessions. In other words, 1 session a week. Give them a lot of homework and things to do at home. They get homework from the physios and the speech therapists and the occupational therapists, and eventually it's nice to see them recover. So the long and the short of this is, we only see what we know. I'm sure that everybody knows about Prof. Larry Alexander. He sadly passed away a year or 2 or 3 ago, but he was a great, great, great teacher. And he was so astute in his academic knowledge of various fields. And it's so important for us to remember that in order for us to know how to help patients, we have to keep on learning. I thank you.